So, sir, with all your permission, we are getting started now.
Yes.
So, may I have your attention, esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good morning and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. And it is with great pride that Clarinet serves as a digital partner for this online event jointly hosted by the Indian Association of Cardiovascular Thoracic Surgeons, Indian College of Anaesthesiologists, Karnataka chapter of IACTA, Global Intensive Care Symposium, International Society of Cardiac Ultrasound, and Global Heart Care Foundation, USA. So let me introduce today's focus of session, which is mitral valve anatomy, 2D and 3D TEE. So, well, to start with today's Sunday TEE session, I would like to present before you a short welcome video.
Good morning and welcome to this Sunday breakfast session on echocardiography, which deals with transesophageal echocardiography and critical care echocardiography. Thank you for joining us, and I'm greatly delighted to note that the two eminent faculty from our national level, actually they are international if I can say so, Dr. Thomas Koshi and Dr. Satyajit Mishra have joined us today to enlighten us about the mitral valve anatomy. Dr. Thomas Koshi does not need any introduction. He's the president of the Indian Association of Cardiothoracic Anesthesiologists. He's very well read and excellent teacher with a lot of expertise in the field of echocardiography, especially transesophageal echocardiography and cardiac anesthesia. We always look up to him for whenever we are in doubts. And I request Thomas Koshi to introduce Satyajit Mishra, the faculty for today's morning. And before I do that, before I request Thomas Koshi to do that, I request the participants to post their comments and your comments and questions on the chat box. We'll get back to you at the end of the talk. And at that point of time, if you want to unmute yourself and speak, please do so. Till that time, keep your mics muted and the videos off. And with that, I request Dr. Satyajit Mishra to take over and conduct the meeting.
So, thank you, Dr. Muralidhar, for inviting me to moderate this session. And the topic chosen for today, that is the 2D and 3D anatomy of mitral valve, is very important for any practicing cardiac anesthesiologist. If you look at all the structures of the heart, the only structure which is studied maximum number of publications is mitral valve. I mean, even the 3D was discovered or made to image the mitral valve more than any other structure in the heart. A thorough understanding of the anatomy, both 2D and 3D, are required to make a proper diagnosis for the surgeon to make the proper procedure. So it's a life-saving imaging skill for the patient, which is usually not provided by the cardiologist, especially the 3D part. So the anesthesiologist should be having very good skill to direct the surgeon that this patient is fit for or suited for a repair, not replacement. And if it is suited for repair, whether there is some potential, what are the anatomical characteristic, which leaflets involved, what procedure can be done, and that evaluation continues after the procedure also. So to discuss this topic, the eminent faculty, former colleague of me, who worked in Sridhara for many years, Dr. Satyaj Misra. He is the HOD of anesthesia at AIMS Bhubaneswar, and he has got many publications and presentation on this topic. And he is the person to describe both 2D and 3D anatomy of mitral valve. You will have a lot of questions, so please enter the chat box as Dr. Muralidhar told. And we have started working together for a decade. I think a decade back, Satyajit Misra was instrumental in changing the FT examination from a manual examination to computerized based test way back in 2015 in Narana. So I welcome my friend, my former colleague, to present this very important topic. All audience, please listen carefully, and you will have many doubts and can be clear at the end of the lecture. Satyajit, please.
Yeah, thank you, sir, and good morning to one and all. My gratitude to Professor Muralidhar for inviting me on the Sunday breakfast session for this important presentation. And on the occasion of Guru Purnima, I'd like to take a moment to salute my mentor, Professor Koshi, under whose guidance I've learned many things, and I still continue to look forward to him for advice and guidance whenever I have needed it. So much of my echocardiography knowledge was shaped in Sri Chitra, and because of the eminent faculty like Professor Koshi and others who were there, and we learned from each other. We kept on encouraging each other. And so it was a great learning experience at Chitra, which has stood me in good stead at wherever I am. And presently, I am at the All India Institute of Medical Sciences in Bhubaneswar. I'm the Professor of Anesthesiology and Dean of Research. And today's breakfast topic is evaluation of the mitral valve using 2D and 3DT. So I just like to take a moment to ask whether the presentation is on presentation format.
Yes, it is. It is.
And the slides are moving?
Yes.
Yeah. Okay. Thank you. So I would like to start off by saying that I do not have any conflicts of interest or any disclosures to be made here for this presentation. And over the next 30 minutes, how we are going to go through this talk is we will discuss a little bit about the anatomy of the mitral valve, which is important to understand before we jump into the T views. We'll start off with what are the standard routine T views to interrogate the mitral valve. We'll discuss what is the additional role of 3DT, and we'll end with a few interesting cases where both 2D and 3DT has made a difference in the patient's outcome. So the mitral valve is composed of 5 distinct parts. The first is the annulus that subtends the 2 leaflets, and that is the mitral annulus. The leaflets are the anterior mitral leaflet and the posterior mitral leaflet. The leaflets are in turn supported by the chordae tendineae, which arise from the papillary muscles, and the chordae insert into both the anterior and the posterior mitral leaflet. And the papillary muscles in turn are a part of the left ventricular wall. We'll just explore a little bit in details about each of these components of the mitral valve, which is important to understand so that we can appreciate how the valve dynamics play out in various disease states. Now, if you look at the leaflets, this is a 3D view, on-face view from the atrial side. And the 2 leaflets, like I mentioned, they are the anterior mitral leaflet and the posterior mitral leaflet. Now, it's obvious that the anterior mitral leaflet is the larger of the 2 leaflets. It's around nearly 2 times the size of the posterior mitral leaflet. There are 2 distinct scallops on the posterior mitral leaflet, or indentations, which divides the leaflet into 3 parts. And there are no indentations on the anterior mitral leaflet, but the corresponding anterior mitral leaflet is also divided into 3 scallops to correspond with the terminology of the posterior mitral leaflet. Now, the anterior mitral leaflet is broadly semicircular in shape and occupies around 2/5 of the mitral annulus, whereas the posterior leaflet is around is approximately quadrangular in shape and occupies 3/5 of the mitral annulus. Now, when you look at the area occupied by each of the leaflets, it's roughly the same, and the area would be around 140 millimeters square of the total mitral annulus. So there's a little bit of redundancy as compared to the total mitral annular area, but that is important so that there is proper cooptation of the leaflets in systole. Now, the atrial surface of the leaflets is smooth, but the ventricular surface as well as the coapting surfaces are rough. Now, the most important thing about the mitral valve is the annulus, and it's very uniquely shaped. Now, we have all eaten a packet of chips, and if we see the shape of the chips, that's exactly how the shape of the mitral valve annulus is. It's also described as a non-planar saddle-shaped structure, where the commissural diameter, or the lowest part of the mitral valve annulus, is longer than the highest part of the mitral valve annulus, which is the anterior-posterior diameter. Now, this unique configuration of the mitral valve in a non-planar mitral valve annulus in a non-planar saddle-shaped structure is to maximize the ventricular valvular energy conformation, so that in systole, with the closed position, there is least stress on the mitral valve leaflets. Now, any other shape, if it becomes more dilated or more flat, would result in more stress on the mitral valve leaflets, preventing proper coaptation of the mitral valve leaflets. The highest points of the mitral valve leaflets are opposite the anterior annulus. The highest part is at the A2 level, and on the posterior annulus, the highest part is opposite the P2 scallop. Now, when you look at the distribution of the chordae arise from the papillary muscles. There are 2 papillary muscles, the anterior papillary muscle, or the anterolateral papillary muscle, and the posteromedial papillary muscle, or the inferomedial papillary muscles. Now, the chordae arise from these papillary muscles. They are fibrous structures, and roughly they extend around 2 centimeters before they are inserted into the mitral valve leaflets, and they are roughly 1 to 2 millimeters thick. Now, each of the papillary muscles gives the chordae to both the leaflets. So the anterior papillary muscle gives chordae to both the anterior and the posterior leaflet, as well as the posterior papillary muscle gives chordae tendineae to both the anterior as well as the posterior mitral leaflet. Now, the order of the chordaes is such that there is a primary chord or the marginal chord. So this inserts into the free edges of the mitral valve leaflet on the ventricular surface. Then there are the secondary chords which insert into the body of the mitral valve leaflets, and there are some tertiary chords which arise directly from the ventricular wall, and they insert into the posterior mitral leaflet. Coming to the papillary muscles, the anterior papillary muscle usually has 2 heads, the anterior and the posterior head, and the posterior papillary muscle has 3 heads, the anterior, the intermediate, and the posterior heads. Now, the anterior papillary muscle has a dual supply. It's supplied by both the left anterior descending as well as the left circumflex, whereas the posterior papillary muscle has usually a single coronary artery supply. In the right dominant circulation, it is the right coronary artery that supplies the posterior papillary muscle, and in the left dominant circulation, it is the circumflex that supplies the posterior papillary muscle. So this arrangement of the coronary artery distribution to the papillary muscles is important, because usually the coronary artery abnormalities impact the posterior papillary muscle because of the single supply. So one tends to have more cases of posterior papillary muscle infarct because of the occlusion of the arteries, culprit vessel, rather than an anterior papillary muscle infarct. And because there is a posterior papillary muscle infarct, the posterior leaflet will be more impacted with that. Now, the subvalvular apparatus is quite gross. It's not very simple. Think of it like a medusa's head, with the face of the medusa as the papillary muscles, and all these snakes coming out of the medusa as the quadi tendini. So this is exactly what a gross anatomy of the subvalvular apparatus looks like. And you can see how complex the dynamics is. And the whole idea is that the mitral valve is one apparatus that consists both of the mitral valve annulus, the leaflets, as well as the subvalvular structures which belong to the left ventricle. Now, when you look at the mitral valve nomenclature system, it is important to understand how the nomenclature works. Now, the Carpentier system, which is followed world over more commonly, it basically follows the leaflet morphology in naming the leaflet scallops. So the posterior, like I said in my previous slide, the posterior mitral leaflet has two indentations, which divides the posterior mitral leaflet into three scallops, the P1, P2, and the P3. There are no indentations on the anterior mitral leaflet, but corresponding opposite segments are termed A1, A2, and A3 scallops. Now, there's another classification called the Durance classification. In it, the classification is not based on the leaflet morphology, but based on the attachment of the quadi tendini to the leaflets. So all the leaflet portions that are attached to the anterolateral papillary muscles is termed as so if you just draw an imaginary line dividing the mitral valve leaflets into two equal halves, so all those on the lateral side here are attached to the anterolateral papillary muscle, and all those on the medial side are attached to the inframedial or the posteromedial papillary muscle. So the A1, P1, and PM1 segments are attached to the anterolateral papillary muscle, and the A2, P2, and the PM2 segments are attached to the posteromedial papillary muscles. But even this was insufficient classification, because you see, there is a part between the A1 and A2 which does not have any terminology. So it's not very clear whether this is attached to the lateral papillary muscle or to the medial papillary muscle. So the modified Carpentier, which is now included both the Carpentier classification as well as the Duran classification. What they did was they further divided the middle portion of the anterior mitral leaflet into a lateral half and a medial half. So that makes it more anatomically relevant segments. Now, if you draw the same imaginary lines, you have the A1 and the lateral portion of the A2 scallop, as well as the P1 and the opposite segment, that is the lateral portion of the P2 scallop and the commissures. All these are attached to the lateral papillary muscle or the anterolateral papillary muscle. And then the medial portion of the valves, that is the A2 medial segment, the A3, the P2 medial segment, and the P3 as well as the medial commissure, they are all attached to the posterior medial papillary muscle. So this is much more anatomically relevant classification, which incorporates the best of the Carpentier as well as the Duran's classification. Now, when we look at the essential differences between the mitral valve and the aortic valve, now, if you look at the arrangement, the mitral valve is basically anchored to the LV by with the help of the quadi tendini and the papillary muscles, whereas the aortic valve is basically suspended from the aortic annulus and the sinotubular junction. If you just think, there are no attachments of the aortic valve onto the LV. So anatomically, the mitral valve is as much a part of the left atrial annulus as it is that of the left ventricle, whereas the aortic valve belongs more to the aorta and the aortic root. When you look at the parts of the mitral valve, I told you there are 5 parts. There's the annulus, there are the 2 leaflets, the quadi tendini, the papillary muscles, as well as the ventricular walls that give rise to the papillary muscles. And then there is the aortic valve. The parts are the annulus, the cusps, the aortic sinuses, and the commissures. So it stands to reason, and it's a no-brainer, that the LV dysfunction after the valve replacement is going to be maximal after a mitral valve replacement, because we are playing around with the LV morphology, whereas it's going to be minimal after an aortic valve replacement because the LV is not handled in any way. So coming with this background knowledge of anatomy, let us start off with what are the usual 2D views we use for the assessment of the mitral valve. Now, there are 4 midesophageal views and 2 transgastric views, and each has a role. So we start off with the midesophageal 4-chamber view with a multiplane angle at 0 degrees. I'll be taking you through each of these views in detail. And basically what we look for is we look for the morphology of the valve. It's very clear. The morphology of the valve is very evident in this view. We look for stenosis and regurgitation, and we use this view to quantify the severity of the stenosis because of the parallel alignment of the Doppler with the flows. Then moving on, as we rotate the multiplane angle to 50 to 70 degrees, we come upon the commissural view. And usually this scan line passes through the P3, P1, and A2 segments. We don't usually see the P2 scallop of the mitral valve, but posterior mitral leaflet, but we do see it if there's a P2 prolapse, in which case it appears like a cobra head behind the A2 scallop. We also see both the papillary muscles in this view, the anterolateral as well as the posteromedial. And this is an excellent view if you want to see for commissural leaks. The midesophageal 2-chamber is obtained. It's an orthogonal view to the 0 degrees, so it's obtained at 90 degrees. And there are various parts of the anterior mitral leaflet or the posterior mitral leaflet, depending on the rotation of the probe, whether you're rotating it more to the left or more to the right. The midesophageal long axis, so this is basically the 3-chamber view, and this is at 120. And this is the view which cuts the mitral valve in an anteroposterior direction, and reliably it cuts the valve at the highest points on the mitral annulus, that is the A2 and the P2 points. So this view is very useful for SAM prediction, as Sir Koshi sir said that often we use the 2D and the 3D to gain knowledge of whether there's going to be SAM after a mitral valve repair or in patients with hypertrophic cardiomyopathy. So this view is an excellent view for evaluating whether there's going to be a residual SAM after a mitral valve repair. Going on to the transgastric views, we have 2 transgastric views. One is at 0 degrees, and this is a good view if you want to go for a planimetered valve area. And the other one is the transgastric 2-chamber, which is obtained between 90 and 110. And this is an excellent view for determining the subvalvular apparatus, because the image is perpendicular to the ultrasound beam. So the image resolution is very high, and the subvalvular apparatus can be studied in great detail. So we all know, I won't go through the details of this. I'll cover it in individual views. But as we all know that depending on how the scan line cuts at various, as we change the multiplane angle from 0 to 120 or 130, there'll be different scallops of the mitral valve that are cut. To give you an example, at 45 degrees or between 45 and 60, which is the commissural view, the scan line from lateral to medial, it passes through it passes through P1, A2, and P3. So the P2 segment is not usually cut in this scan line. And the only time you can see a P2 scallop is when there is a P2 prolapse as it appears behind the A2. Similarly, at 0 degrees, the scan line passes through A3, A2, and P1. So depending on how the scan line passes, you will cut various scallops of the mitral valve. And each of these midesophageal views is important to study the mitral valve in entirety, because it's a 3-dimensional structure and we are seeing it from a 2-dimensional view. So we can't comment on the valve using just any 2-dimensional views. We have to rotate it through 0 to 120 or 130 in all the 4 views to give a more definitive picture on the mitral valve morphology and the disease pattern. So let us start off and see each of the views in a little bit more detail. So we start off with the multiplane angle at 0 degrees, which is the midesophageal 4-chamber. And I understand that I would like to assume that there is already the innate T knowledge amongst the viewers. So I'm not going to go through the details of the structures that we see. I'm just going to focus on the mitral valve. So the scallops that you usually see in this view, so this is the patient's right and this is the patient's left, but this is the image left and this is the image right. So on the right side of the screen, we are seeing the left heart structures. On the left side of the screen, we are seeing the right heart structures. So Between the LA and the LV is the other two mitral valve leaflets. And the scallops that are usually interrogated in this view are parts of the A3, A2 and P2, P1. Now, if you pull the probe up a little more, that means the probe is at a shallower depth, around 30 centimeters. With the aortic LVOT and the aortic root in picture, you will cut more lateral portions of the valve. You will cut the A2 and A1 and the P1 scallops of the mitral leaflets. Now, this is a good view to also see if there is a aortic regurgitation. You can't quantify the regurgitation or the stenosis because this is not aligned with the Doppler, but just a bird's eye view of whether there's severe aortic regurgitation or even aortic stenosis. Now, from the midesophageal forechamber, as you push the probe in with the coronary sinus in view, the arrow points to the coronary sinus. You will see more medial portions of the valve of the leaflet scallops. So you will see the A3 scallop as well as the P3 scallop. So from a midesophageal forechamber view, pulling the probe up and pushing the probe in, you can cut the different scallops of the mitral valve leaflets. What are the utility of the four-chamber view? It's quite a useful view. Like I said, it's very well aligned with the Doppler. So you can quantify the severity of the stenosis or even for the severity of the regurgitation by measuring the vena contracta or the pisa. Also, you can see for any LA clots, whether in the appendage or whether in the roof of the LA. When you rotate the multiplane angle further to 60 degrees, this is called a commissural view. So it cuts the mitral valve at the two commissures, that the medial commissure and the lateral commissure, as well as the various portions of the mitral valve leaflets. So from moving from left to right, you get P3, A2, and the P1 scallops. Moving from left to right on the image. Otherwise, we are moving from the patient's right to left. So P3, A2, and P1. And this is also called a seagull appearance. This is the head of the seagull, and these are the wings of the seagull. So this is like a seagull. So this is called a seagull appearance. And the utility of this view, like I mentioned earlier, is for interrogating commissural leaks, as well as for seeing the P2 prolapse in cases, as well as seeing the cobra head appearance in cases of P2 prolapse. When we rotate the multiplane angle further to 90 degrees, we sort of cut the mitral valve anterior leaflet in its entirety. So from the appendage, LA appendage to the coaptation point, you get the A1, A2, and the A3. And opposite the coronary sinus, you get the P3 scallop. So this is how the two-chamber views are. If you move the probe a little more leftward, you will cut more portions of the posterior mitral leaflet. Now, when we move the probe multiplane angle, rotate the multiplane angle further to 120 degrees to 130 degrees, we cut the mitral valve at its highest points on the annulus, and the leaflets opposite that are the scallops opposite that are the A2 and the P2 scallops of the anterior and the posterior mitral leaflet. Now, this is the only view where we can say with certainty that which scallop of the mitral leaflets we are cutting. So we are cutting the A2 and the P2, which are the highest points on the annulus. And this is an excellent view that is well aligned with the Doppler. So you can use it for interrogating the hemodynamics across the mitral valve, as well as this view can be used for many other things like measuring the tenting area, the tenting height in cases of ischemic MR, as well as for measuring the C-sep distance for SAM prediction, and so on and so forth. So that once you are done with the mid-esophageal views, we push the probe in further. And remember that whenever you're seeing the mid-esophageal views, the probe manipulation is retroflexion because the apex is below the level of the probe. But when you're pushing the probe into the mid-esophageal position, because now the apex lies above the level of the probe, you have to sort of anti-flex to look to cut the ultrasound from the apex towards the base. So once you do that, you get the transgastric basal short axis view. The anterior mitral leaflet lies in the far field and the posterior mitral leaflet lies in the near field. And you can see the various scallops, A1, A2, A3, as you move from a lateral to a medial interrogation. Now, this is a good view to measure the planimetered, to evaluate the planimetered valve area. You can freeze and you can see which is the largest, you can scroll and diastole and you can see which is the largest frame, in which frame there's the largest leaflet opening, and you can do the planimetered valve area. But understand that we may be overestimating the valve area because we do not know exactly which is the narrowest point of the valve where the hemodynamic abnormalities occur, which is something that we can do better with 3D TEAM. Now, the last 2D view for interrogation of the mitral valve anatomy is the transgastric two-chamber, obtained usually in the transgastric position. You rotate the multiplane angle from 0 to 90 degrees. And you can see an excellent view of the subvalvular apparatus, which is important to understand how it is impacted in various disease processes like mitral stenosis, where there would be subvalvular fusion, there'll be thickening of the chordae tendineae, and even the papillary muscles may get pulled up. So this portion of the leaflet at the far end of the screen is the anterior mitral leaflet, and the posterior mitral leaflet is not very clearly visible. But what I want you to appreciate is how you can see in systole, when the ventricle contracts, how the papillary muscles sort of thicken and the chordae become taut. And that is important to prevent mitral. This is important for the coaptation of the valve and prevent the valve from leaking into the LA during systole, because the closing forces that are there, they may force the valve to sort of open up and prolapse into the LA and cause mitral regurgitation. So this is prevented by the thickening of the papillary muscle and the taut conformation of the chordae tendineae. Whenever we discuss the mitral valve diseases, it's always a physiological triad that we should think of when we are discussing the mitral valve disease. So first is the etiology of the disease. Then what are the specific lesions it causes on the valves? And what are the hemodynamic consequences of the valves? Now, we all know that the Carpentier mechanism is there to describe the various categories of the MR. So using this, we should be able to describe each of the three aspects that I just discussed. For example, if we are looking at a type 2 mitral regurgitation. So the etiology of the disease would be a myxomatous mitral valve disease or a mitral valve prolapse. The specific lesion it causes on the valve may be either a flail or a prolapse. And what are the hemodynamic consequences of the lesion? So hemodynamic consequences is what is the impact of the disease on the LV, what is the impact of the disease on the LA, and what is the impact of the disease on the pulmonary circulation. So whenever we are talking of the mitral valve disease, we should be able to describe it under these three categories, and that is the pathophysiological triad of the mitral valve disease. So let us now come to what is the additional role of 3DT. So 3DT is an excellent tool to study the mitral valve morphology in one go. You don't need to rotate the multiplane angle through various, you don't need to rotate the 2D image through various multiplane angles. You can just, at one instance, you can just delineate the entire valvular morphology, and both from the atrial aspect as well as from the ventricular aspect. It's also an excellent tool to determine the mechanics of the mitral valve with mitral valve quantification softwares. I'll be giving you a few illustrative examples of that. For localizing paravalvular jets, it's a wonderful tool, especially after a mitral valve replacement, when there is a lot of mitral alveolar calcification. It's also a good aid to 2DT in further discriminating complex clinical cases. And for the cardiologist, it provides procedural guidance. For example, procedures like mitral clip, 3DT is a must, without which they will not be able to deploy the clip. So looking at the first aspect, when you look at the morphology of the mitral valve, or for that matter of fact, any valve with 3DT, it's a wonderful tool. It's a wonderful tool to understand the morphology as well as to teach the morphology to the students. So this is a thickened valve. You can see how the thickened valve appears in patients with rheumatic heart disease. The valve leaflets are grossly thickened, and you can even visualize the opening snap here. I mean, we always read about the opening snap and all. You can also visualize the opening snap here, if I may say so. And this is from the atrial side. And you can see the same thing from the ventricular side. And from this part, the second picture on the right, you can appreciate the fish mouth appearance, where the commissures are almost fused, and there's only a narrow orifice that the entire inflow to the LV is presented, and that is the reason for the hemodynamic, for the gradients across the mitral valve. And that becomes exaggerated in patients with increased blood volume, as in patients with pregnancy. So you can just imagine, once you see this, you can totally understand the hemodynamics of the mitral valve in patients with MS. This is also a wonderful view. If you want to do a planimetered valve area, this is a wonderful view. You flip the image from the ventricular side, and you can freeze, and you can do the planimetered valve area. And probably you will be cutting it at the lowest point, at the narrowest point of the mitral valve orifice. You can also guide where exactly you want to measure the planimetered valve area by putting the markers across the mitral valve, and you can bring it down to the narrowest point, and the same narrowest point would correspond to the 3D image, and you can do the planimetered valve area. So this is an example of how the planimetered valve area has been done, and you can see that the planimetered valve area is around 0.4 centimeters square, which fits into the category of severe MS. So more on the morphology part, you can see that in this patient from the atrial side, the arrow points to an isolated P2 prolapse, which is one of the most commonest causes of mitral regurgitation, especially in elderly patients. Similarly, it's a wonderful tool to visualize the intracardiac masses, in which in this case you can see that this is the septum, and there's an intracardial, there's a mass in the left atrium that is attached to the interatrial septum, and you can even appreciate the stalk of the mass. And if you flip it, you can also see the mass plopping in and out of the left ventricle in diastole, and you definitely know that if this situation happens, then this case could lead to a functional mitral stenosis, which would be an indication for surgery in these patients. So this is a very good tool for teaching and training. And also you can see how the 3D, you can see this, appreciate this arrow is pointing to the sickle-shaped deformation of the anterior mitral leaflet in systole. So that is a systolic anterior motion of the mitral valve. And once this redundant tissue is there in the LV outflow, this is the reason for the hemodynamic abnormalities and the gradients that develop in the LVOT coupled with hypotension in these patients. So even let alone native valves, after the prosthetic mitral valve is put, you can not only you can functionally evaluate the prosthetic mitral valve in terms of the gradients, you can also see the occluder motion. You can see the sewing ring, whether there's a rocking moment of the sewing ring. You can see the sutures, whether there's any suture dehiscence, and so on and so forth. So this is a wonderful view to evaluate the prosthetic mitral valve function after mitral valve replacements. Now, when we talk of mitral prolapse, there are a lot of terminology, and I want the residents to appreciate the difference between prolapse, billowing, and fail. Now, when we look at a mitral valve prolapse, essentially what we are saying is, if you look at the top image panel, the image A, there's a black line, which is the annular level. So in the patients with prolapse, what happens is that the coaptation point overrides the annular level. That means that it goes above the level of the annulus. So in the 2D echocardiography in the panel B, you can see that the coaptation point is above this red line, which is the annular level. And even in the 3D, you can well appreciate that the coaptation point is almost, the mitral valve leaflet is almost pushed into the LA. In panel D, the coaptation line is below the level of the annulus, the black line. The parts of the leaflet are billowing out. So this is well appreciated here on the 2D image also. You can see that this arrow points to the coaptation line, which is below the level of the annulus, and parts of the leaflet tissues are billowing above the level of the annulus. So this is something like this. So many patients with myxomatous mitral valve disease would present with this kind of a picture. Whereas in flail, you will have a free edge of the leaflet tissue. This arrow points to the free edge of the leaflet tissue that is floating in systole and well above the coaptation line, well above the annular line, I'm sorry. And you can see that in this 3D image also, you can see this flail segment on the posterior mitral leaflet. So this is important for us to understand the morphology of prolapse, billowing, and flail using both 2D as well as 3DT. Whereas 3DT plays a role is there's a wonderful tool called mitral valve quantification that's available on both the GE and the Philips platforms. And this mitral valve quantification tool allows us to do a plethora of measurements. For example, you can measure the anteroposterior diameter. You can measure the intercommissural diameter from the anterolateral to the posteromedial papillary muscle. You can measure the annular height. If you look at the lower image, the annular height would be the vertical height from the anteroposterior diameter to the lowest point, that is the commissural diameter. And by doing all these measurements, you can look at the annular non-planarity index. Basically, the non-planarity index means the mitral valve is not planar, it is non-planar. That means it's a saddle-shaped structure with the highest points at the anteroposterior diameter, lowest points at the commissural diameter. So the annular saddle shape one can determine by determining the ratio of the annular height to intercommissural diameter. And in a subsequent slide, I'll show you why all these things are important. Also, you can look at the leaflet geometry. You can look at the total surface area of the individual leaflets. You can look at the coaptation line. You can measure the leaflet heights, and so on and so forth. You can measure the aortic to mitral valve angle, and we know that patients with a narrow angle of less than 120 degrees, these are the patients who may predispose to SAM post mitral valve repair or after hypertrophic cardiomyopathy. Again, the subvalvular geometry, you can make a lot of measurements. You can measure the papillary muscle to the papillary muscle to the fibrosa, annular fibrosa, the interpapillary muscle distance, and all these measurements are very important in patients with ischemic mitral regurgitation where there's a significant ventricular remodeling. So look, this is a wonderful article that was published in Circulation in 2021, I think. And they looked at the mitral valve dynamics using a combination of 2D, 3D, as well as mitral valve quantification softwares. And when you look at the normal mitral valve, if you appreciate the normal mitral valve, look at the mitral valve quantification on the extreme right of the panel. The aortic annulus is designated as a circular ring, and the mitral annulus has the anterior and the posterior points. You can appreciate the saddle-shaped structure of the mitral annulus, and this is the normal mitral valve with the normal leaflet geometry. Now, as there is regurgitation, even if it's a minimal regurgitation, as in the second image B, now you can move on to the 3D image of that. So there's a minimal regurgitation here, and there's a deformity of the mitral leaflet, maybe the posterior mitral leaflet. You can see that now the mitral valve quantification, if you move on to the mitral valve quantification image, you can see slowly the saddle shape is losing its saddle structure, and it's becoming more flat. And there's a little bit of a billowing on the posterior mitral leaflet here. You can see this annular geometry. You can see that there is a little bit of a hump in the posterior mitral leaflet. As the regurgitation becomes worse, and there is now an isolated prolapse of the P2 segment, you can see that the mitral valve is becoming more and more flat. And this red portion on the leaflet geometry, it shows that the billowing volume has become more. And when there is myxomatous mitral valve disease, multiple parts of the mitral valve are prolapsing. You can see that this has almost become a flat ring rather than a saddle-shaped ring. And these multiple red areas point to the multiple areas of billowing in the leaflet geometry. You can see that there are multiple red areas which point to the multiple areas of billowing. So this is a wonderful tool to sort of study how the mitral valve disease affects the mitral valve annular as well as the leaflet dynamics. It's also important, one has to understand that we have moved from flat shaped rings to saddle shaped rings simply to preserve this annular structure. So if you put a more flat ring, this is what happens if you put a more flat ring when the surgeon is going to go for the mitral valve repair, you're putting a flat ring. This is exactly what the surgeon will do to the mitral valve annulus. Look at the last image where the annulus is totally flat. And if that happens, the ventricular as well as the valvular dynamics are not going to be good. Whereas if you put a saddle-shaped ring, the shape of the mitral valve annulus is preserved, and so also is the ventricular valvular interdynamics. Another important point in advantage of 3DT is locating the paravalvular leak with after a mitral valve replacement. Now, all of us from our 2DT knowledge know that if the surgeon asks where the leak is, we have to imagine the face of a clock and rotate the multiplane angle through various views, and then see whether the regurgitation is happening in the fourth chamber at the septal side. So if it is A, that's a 6 o'clock position. If it is B, that's a, if it's A, it's a 12 o'clock position. If it's B, it's a 6 o'clock position. So in a 2-chamber view, if it is C, it's a 3 o'clock position. If it is D, it's a 9 o'clock position. So, you have to do the hard job of rotating the multiplane angle and then scratching your head and then telling the surgeon, because the surgeon would like a precise information where exactly is the paravalvular jet, so that he can go bingo in one go. He can just straight away approach the target area and then close that paravalvular jet. If you're not going to give an accurate information, the surgeon is again going to search for that paravalvular leak, which may further delay the time on pump and the patient's outcome. So this is where 3DT also comes handy. So here, if you see, this is a simulation model. So this is basically a commissural view, which is almost close to a 2-chamber view. So the leak is at this position, or the position D, and the position D is on the 9 o'clock position on the clock. So When you put it in a 3D configuration, you can straight away see that the regurgitation paravalvular jet is at 9 o'clock position, and you can straight away give that information to the surgeon. So I'll just like to show you an actual clip of that. So this is a patient we had post CPV. Just try to see the panel, top left panel. You can see that on the medial side, there is a small jet that is outside the sewing ring. I don't know if you can appreciate it. It's a very small jet. And when we put a 3D, so you can see most of the flow is within the sewing ring of the valve. Appreciate the sewing ring of the valve here. Most of the flow is there. But if you just look at this septum side, there's a very small leak here. So you can immediately tell that there is a leak, paravalvular leak, and where it is if you just imagine it according to the face of a clock. Now, important thing for most of us to understand is if there is a paravalvular leak, whether we need to address all leaks? No. Most of the leaks will settle after protamine. So only if the leak is causing a significant hemodynamic abnormality or you're unable to separate from bypass is when you tell the surgeon to go and address the paravalvular leak. So I'll finish off with a few interesting cases where both 2D and 3D TE were useful. So this was a patient who had a 25 millimeters Sanjute bileaflet mechanical prosthesis, and post prosthesis, we could see that there was a new mass that was attached to the that appeared attached to the aortic valve, this arrow and the circular mass. And this mass was also visible in the in the aortic valve short axis view. So that pretty much told us that the mass was a real mass and not an artifact. So when you want to rule out an artifact, you have to go to multiple views. And then if it's not visible in multiple views, then it's pretty much an artifact. But because this was visible in multiple views, we knew it was not an artifact. So we thought that where is this mass coming from? So we put the 3D to the 2D and we flipped it to the ventricular surface, and lo and behold, you can see that what appears to be a papillary muscle has been sutured to the underside of the sewing ring when we are viewing it from the left ventricular side. So when the surgeon was trying to preserve the subvalvular anatomy, he somehow managed to chop one head of the papillary muscle, and without realizing it, he anchored it to the underside of the sewing ring. So we reported this in the JCVA. And another similar case was there in a patient with mitral valve mitral stenosis. You can see the very high basal position of the papillary muscles. Normally, the papillary muscles are between the middle and the apical third of the left ventricle. So here you can see a very high basal position of the papillary muscle. And that is because the papillary muscle has been pulled up secondary to caudal fusion and shortening. And when we interrogated with color flow Doppler, we could make out that there were two distinct jets, one at the valvular level and the other at the subvalvular level. So we did not get separate gradients for this because we know from our physics that if there are multiple jets, the jet with the highest velocity will be interrogated along the pathway of the jets. So we got one gradient only. But the importance of these multiple jets is that when you have such a high basal position of the papillary muscle, the surgeon has to take a call on whether to preserve the subvalvular apparatus, because once he puts the prosthetic valve, the high position of the papillary muscles may interfere with the proper functioning of the occluders in the occluder opening and closing. So sometimes you may have to sacrifice the subvalvular apparatus, especially if the papillary muscles have been pulled up in patients with severe mitral stenosis. So last, I would like to just this, and I would like to ask the audience, they can put it in the chat box, their diagnosis. And if you have still not been able to make a diagnosis, we can discuss this during the discussions. With this, I would like to end my talk. And thank you all for a very patient hearing.
Satyajit has given an excellent lecture on anatomy, physiology, and pathology of mitral valve with beautiful illustrations, both 2D, 3D, as well as cartoon diagrams. He has explained the classification of Carpentier, Durand, and the latest Carpentier modification, and illustrated the anatomy, physiology, and the etiology of mitral valve abnormalities in a brilliant way. Interesting images at the end. So the lecture is open for discussion. And before I hand over to the audience, you can put your questions in the chat box, and Anaesthesiologist will direct it to Satyajit. So that paravalvular leak, it appears to be mild. Did the surgeon do anything for that?
No, we did not go back on pump, sir. We left it as it is.
Because it is a small to be interrogated.
It was a trivial leak.
Okay. Congratulations, Satyajit, and you can answer the questions.
Thank you, Satyajit. Excellent presentation.
Thank you, sir.
And there are two comments which have said that brilliant and excellent presentation. Thank you so much. I agree with that comments.
Yeah. So here somebody has mentioned Alfieri stitch. That is I would say that the answer is I would accept the answer. Actually, it's a mitral clip, this post mitral clip. So usually it just appears like a figure of 8 stitch or an Alfieri stitch. So that is a percutaneous Alfieri stitch, if I may say so. Yes, that answer is correct from Arnab. He has answered it correctly.
Thank you. See, you mentioned that nothing was done to that mild paravalvular leak because in such cases, these patients may develop hemolysis. And what is your strategy if you get that?
Yeah, sir. Thank you for asking this question. So usually what happens is if it's a very small leak and it's not hemodynamically significant, the dictum is that the paravalvular leak is left best alone, because it's very difficult to spot these once you go back and try to locate these small leaks, gaps. It's very difficult for the surgeon to find the gaps. But in case the patient presents with hemolysis, it is important to consider closing that with a percutaneous PFO device, so that the cardiologist can do the job. So that is reserved for later. If there is hemolysis, then it is closed with a PFO device.
Right. I agree with that. Actually, one of the cases we had, the patient was hemodynamically stable, and on the first day there was some paravalvular leak causing hemolysis. Because patient was stable, the surgeon told us to extubate the patient, and then we can deal with it later with the device. That's what was done in the case, exactly as you explained. And there are a couple of questions on the chat box. Dr. Koshi, do you want to go through them?
Sir, you can direct. I am not seeing the chat box. Yeah, I can see.
One is about explain the angles of TE cuts mitral valve.
So you want me to go back to the presentation again, or
Yeah, your initial first slide, he says.
Okay, so I have to
The angles of TE cuts.
We'll take the other questions first, sir, and then maybe at the end, if there is time,
Okay.
we'll come back to this.
Please explain surgeon's view of mitral valve.
Yeah, so the surgeon's view is the on-face view of the mitral valve that we see. And when you want to see that view, what is the important thing is you have to put the aortic valve at the top. That means the aortic valve has to go on the 12 o'clock position. And then you see the surgeon's view of the mitral valve with the anterior mitral leaflet above in continuity with the aortic valve, and the posterior mitral leaflet below. So in that case, the lateral is to the surgeon's left, and the medial is to the surgeon's right. The lateral commissure is to the surgeon's left, and the medial commissure is to the surgeon's right. So that is the surgeon's view of the mitral valve.
The next question is, how do we quantify paravalvular leak?
Okay, so you can quantify it using a lot of parameters. The first parameter would be obviously the echocardiographic parameters, and the second is the hemodynamic parameters. The echocardiographic parameters would be it's the same way as you quantify a regurgitant jet. So if it's more than 3 millimeters, then you would call it a moderate paravalvular leak. So this is one of the echocardiographic criteria. Second is you see for the movement of for the prosthetic stability. If it's a rocking boat movement, that means that the paravalvular leak that you're seeing is probably a significant leak. And third is you see the patient's hemodynamics. If despite 2 inotropes, you're not able to separate from bypass, then obviously that this is a patient where the paravalvular leak needs to be addressed by going back on pump.
And also, can you look at the circumferential involvement? If it's more than 30% of the circumference involved, you would say that it's severe.
Yeah, we can say that, yes, sir. Thank you.
Next
there is a
question is,
question from Karthik.
yes.
Karthik Jainam, can a prosthetic mitral valve cause SAM?
No, one of the treatment for SAM, which is not resolving to your standard hemodynamic maneuvers like your fluids and vasoconstrictors, is you have to replace the native mitral valve. You have to go in for a prosthetic mitral valve. So the prosthetic mitral valve is the treatment for SAM. It cannot cause SAM.
And the next question from Puneet, how big a paravalvular leak can be left unaddressed?
Sir, I think we covered that. So anything that causes significant hemodynamic abnormalities or is significant on echocardiography needs to be addressed. And if the hemodynamic changes start in the ICU, then it's tough because then one has to decide if you need to bring the patient back to the theater or whether you need to take the patient to the cath lab to sort of close the leak.
I think I can add to that. See, paravalvular leak, there is no problem with mild and severe, because mild can be left alone, severe has to be
addressed. Yes.
So the moderate is the one issue which the anesthesia has to be very clear. It is moderate and then discuss the surgery. But mild and severe, absolutely no ambiguity there. What has to be left alone, other has to be treated.
So the other thing is that if the paravalvular leak is also associated with the rocking boat movement of the valve, then it has to be addressed. So if the hemodynamic changes start in the ICU, you'll have to see why the changes started late, and probably it may be a suture dehiscence or something like that. And so the patient needs to be taken back to the theater and addressed. The leak needs to be addressed.
Yeah. So you should understand the pathology or etiology of the paravalvular.
Absolutely.
Correct. Absolutely right. And thank you for the wonderful presentation. Satish, you are my examiner in FT. Okay. These are good comments. Any more questions? We have got some more time.
Dr.
We have 4 minutes left.
Dr. Koshi Murlidhar, can I say
Yes,
something?
absolutely. Please feel free.
Okay, this is Guru Purnima day today, so I am going to you all. And Satyajit is so lucky to be with his teacher today on this platform. And I never miss his lecture, never. And he was very crystal clear. Satyajit, but I wanted, this is our very age-old discussion, 2D better or 3D. Of course, both are important. But isn't the morphology of the valve, like whether it is rheumatic or Barlow's or fibrous, isn't 2D the better thing to diagnose? Because you see irregularity and fibrous strands and calcification better in 2D.
Okay, so ma'am, actually we'll keep on debating about that, but unless you don't have good 2D images, 3D is also pretty much useless. So the whole premise for a good 3D echocardiography is that the 2D images have to be excellent. Yes, you are right. The diagnosis worldwide of mitral valve disease is not made on 3D echocardiography. It is made on 2D echocardiography. So I agree with you that for morphology and even for valvular hemodynamics, 2D is the 2D is the gold standard. But 3D is always complementary to 2D. So you want to look at the mitral valve dynamics in terms of the annular dynamics, the leaflet dynamics and all that. Then you have to add on 3D to it. You can't quantify all those dynamics only with 2D.
Yes. Only thing is, if 3D comes with black and white, I think our brain is used to see black and white. So
no, the 3D, ma'am, I would say the 3D has its role. I mean, we may not be doing complicated mitral valve quantification every day routinely. Maybe that is more by the researchers and cardiologists and all. But if you look at it, the 3D is a wonderful teaching and training tool. I mean, there is no two things that with 2D you have to make a lot of assumptions. You have to imagine a lot of things because it's a 3D structure you are essentially seeing in unidimensional planes. So you have to sort of, the training and teaching becomes that much more tricky for your residents. But if you have one 3D image, in one go, you can just even explain to even MBBS students, they will understand, forget the super specialty students.
your
So I think 3D
answered this Alferi stitch instantly. He's
Yeah.
your student, so it proved that. Yes.
So 3D is an excellent teaching tool. I would say that in our domain, 3D is an excellent teaching tool for all of us to appreciate, and we should use that more as a teaching aid.
And also to show the surgeon 3D is most
Yeah, surgeon,
beneficial.
because somebody asked the on-face view of the LA, the surgeon will only appreciate the 3D views because that is the actual thing that he is seeing on the patient.
And-
I will add on to this regarding 2D and 3D, because this question I raised in Mark 4 to the international experts. You start with 2D or starts with 3D? Because my point was, if you have the first 4-chamber view, then I straight away switch out the 3D and find out the obvious abnormalities, then go back to 2D. It's easier way. Because once you have reached a certain threshold level, the 3D is faster than 2D. That is what my thinking is. And as Muralidhar sir pointed out, the surgeon would like to see the 3D because they have the on-face view, and that is the exact surgical view. So you don't have to go through the entire views of 2D to go to 3D. You can switch on to 3D early. The moment you see the mitral valve, go to a live 3D or a Zoom 3D. We have a early diagnosis, then work on 2D also.
Especially when the surgeon is very fast and wants to immediately go on pump, then one view you can show the 3D view and then the job is done. So there's one last question. I think we can take that LCX post MVR. So it's very simple. You have to, so it's a dictum that for any patient who is undergoing a mitral valve replacement, you should quantify the LCX flows before the valve replacement and try to see the LCX flows after the replacement. And more importantly, if the LCX is damaged, there will be regional valve motion abnormality in the lateral valve. So once you get new onset RWMA, which was present previously not there, then you have to keep a very strong index of suspicion for the LCX being knocked off by the surgeon.
Thank you so much. It's my pleasant duty to thank both the moderator, Dr. Thomas Kuchi, and the speaker, Satyajit Mishra, and all the participants for being with us this morning. Before we conclude, I request Dr. Ritu to play the concluding video. This is about the announcement of the forthcoming PE workshop. Please join us. The dates are 21st to 24th of August. And Ritu, can you please play that
Sure,
video?
sir.
And after that, we'll close the session. And I request you to have a good time this Sunday. Thank you very much. Enjoy your Sunday.
Thank you.
We'll
you all.
see you next
Thank
week.
you, sir. Thank you.
Thank you.
Thank you, dear doctors, for sharing your valuable insights. So I hope you had a seamless experience. So with all your permission, closing the session over here today. Looking forward to host you again. Thank you, everyone. Goodbye, and have a nice Sunday ahead.